Good morning, everybody. Today I would like to speak about an important topic is metabolic alkalosis. Well, the first I would like to bring to you two patient with different diagnosis but with the same problem. The same problem is metabolic alkalosis. In metabolic alkalosis is very frequent in our hospital. 50% of the patients admitted in the hospital have metabolic alkalosis. Okay. In the first case, we have a patient, 70 years old patient is brought to emergency room for vomiting, diarrhea, and dehydration in last 12 hours. He has history of cardiac heart failure and taking furosemide 40 milligrams per day. Our patient is in the physical exam is irritable and blood pressure is low, is 80/50, and her rate is 100 and respiratory rate is 14. In ABG lab test, pH is elevated. Remember, the normal pH is between 7.35 to 7.45. It is less than 7.35 is acidosis, and is greater than 7.45 is alkalosis. Is basic, acid and basic. In our case, the patient has 7.55 is alkalosis. Okay, it's alkalosis, and the diagnosis is the bicarbonate is more than 24, is 28, is alkalosis, and PaCO2 is 50, is greater than 45, and oxygen saturation is 95%, is normal, and sodium is increased is 155, and potassium is 2.90 milligrams per liter, is low, and chloride is low too, is 80 milligrams per liter. Well, how do you know the first is the etiology of this problem? Etiology is, well, you have two options. You have two options. Or you gain bicarbonate, or you lost hydrogen. It's okay. Or you gain bicarbonate or you lost hydrogen, because the problem is metabolic alkalosis. If you gain bicarbonate, if you are taking, for example, a calcium supplement. In calcium supplement, when the patient has taken sodium bicarbonate, but this is not frequent. Or you lost hydrogen. You lost hydrogen, for example, when you have a lot of vomiting, when you have a lot of vomiting, this is very important. If you love vomiting, or you love vomiting, or you have a nasogastric suction, if you love nasogastric suction, or you are when you are taking diuretic, or in contraction alkalosis. Well, in the first case, our patient have a lot of vomiting. That's okay, and have acid diarrhea and dehydration. The first is very important, vomiting, because in vomiting you love a lot high chloride. The best example in pediatric patient is when the patient have hypertrophic stenosis pylori stenosis. This is esophagus, this is the stomach, and this is the pylori. The pylori here, pylorus is here, and in the stenosis of the pylori, the patient have a lot of vomiting in newborn, 4 to 8 weeks of age. Is between 4 to 8 weeks of age. The patient have a lot of vomiting if projectile vomiting. You have the treatment is surgery, of course, and in this case the patient have hypochloremic metabolic alkalosis. This is the best example in pediatric patient, newborn, of metabolic alkalosis. In other case, when our patient have a nasogastric suction, when the patient have a tube nasogastric suction, and in contraction alkalosis. What is contraction alkalosis? Well, contraction alkalosis is this is a nephron. In this case, this is nephron. Okay. This is a nephron. This is glomerulus. This is a nephron, and this is loop of Henle. This is a conducting loop and conducting tube. That's okay. This is a conducting tube. Tube conducting. This is a proximal conducting tube. This is glomerulus. This is afferent arterials. This is efferent arterials. This is a circulation. That's okay. Well, when you have a low bulimia, In this case, our patient have dehydration. When you have low bulimia, you have receptor in this part in glomerulus. You have receptor in justa glomerular cell and produce renin. Renin stimulus in the liver. To use angiotensin and angiotensin to convert angiotensin 1, angiotensin 1 to angiotensin 2, This is the angiotensin converting enzyme. This is in the lung. That's okay? Angiotensin 2. Angiotensin 2 in the adrenal gland. This is adrenal gland. In adrenal gland, stimulus to produce mineralocorticoids, aldosterone. Adrenal gland have three layers. G, F, R. This is a mnemonic. Glomerulosa, vesicular, and reticular. Glomerulosa produce mineralocorticoid. This is aldosterone. In the second layer, vesicular produce glucocorticoid. This is cortisol. This is a stress hormone. And reticular produce sexosteroids. Well, this is in our case is aldosterone. In the external layer produce aldosterone, and aldosterone in these parts in the proximal conductor tube increase the reabsorption of the sodium and increase the reabsorption of the bicarbonate, and the patient lost hydrogen and lost potassium. This is a problem. Our patient have reabsorption, increase the reabsorption of the bicarbonate, and have more alkalosis and lost more potassium and hydrogen. This lost hydrogen and increase the metabolic alkalosis and lost potassium. That's okay. And in the conductor tube increase the aldosterone, increase the reabsorption of sodium, and lost hydrogen and lost potassium. That's okay. This is the aldosterone to produce. This is renin, angiotensin 1, angiotensin 2. Active the in the production of aldosterone, and aldosterone were in the nephron. Remember, you have 2 million of nephron in the kidneys, and produce the metabolic alkalosis. This is a contraction alkalosis, and in our case, our patient are taking furosemide because our patient have cardiac health failure, and when you are taking diuretic, you have metabolic alkalosis. Why? Well, you have the type of diuretic. In this case, this is, for example, this is loop diuretic. The diuretic has furosemide, torsemide, and thiazide diuretic. In thiazide diuretic, you have hydrochlorothiazide. Well, in this case, the loop diuretic in the ascending loop of Henle, in this part, block the sodium, potassium, 2 chloride sympores. In this case, block this in this case, and the patient loss of more potassium and chloride, and increase the hypokalemia. And thiazide diuretic have hydrochlorothiazide. In this case, increase the reabsorption of sodium and calcium, and the patient loves more hydrogen and potassium. But the most important is the diuretic in the ascending limb of Henle, because it's have a more power. This is the problem in contraction alkalosis, and in the patient when the patient have taken diuretic. And this is maintenance. The other half, you need to know about maintenance factor. Maintenance factor is very important. The first is hyperaldosteronism. The second is hypokalemia. Hypokalemia and hypovolemia. It's very important because in this case, for example, our patient have dehydration. When you start with the treatment, if you put a lot of fluid, but you can't to resolve the problem. The problem is, in this case, our patient have hypokalemia, and the hypokalemia is very, very important to treat, because if you can't resolve the hypokalemia, you can't to resolve the metabolic alkalosis. This is very important. Remember, in the cells, in the extracellular space. In the extracellular space, you have 150 milliequivalent of potassium in the extracellular space, and in the intracellular space you have 3.5 to 5.5 milliequivalent of potassium. And if you have hypokalemia in this intracellular space, you have hypokalemia, the potassium travel to intracellular space to compensation. That's okay? Potassium and hydrogen travel to extracellular space. Hydrogen, and to compensation is bicarbonate to intracellular space, and increase the metabolic alkalosis. When you have hypokalemia, you can, to resolve metabolic alkalosis, you need to put potassium in our patient. This is common case. This is more frequent because patient with vomiting, diarrhea, and dehydration is very common. And we have in the second patient, we have, this is uncommon case. Uncommon case, our patient, for example, have 45 years old. Med patient is brought to emergency room for weakness, headache, muscle cramp, and hypertension, 170 over 120, and respiratory rate is 15. In MRI, it's very important. In MRI, you have the patient discovered the right of adrenal gland of the tumor. This is a tumor of adrenal gland, and this is a tumor of adrenal gland. In this case, what happened in this patient? This is a tumor of adrenal gland. This is a tumor of adrenal gland. This is hyperproduced aldosterone, and this is hyperaldosteronism. This is hyperaldosteronism. Remember, hyperaldosteronism is maintenance factor in metabolic alkalosis. And what happened? Increase the resorption of sodium bicarbonate and lost more hydrogen and potassium, and in the conducting tube lost or more hydrogen and potassium in the nephron. And the hyperaldosteronism is the same of a contraction alkalosis, but have hyperaldosteronism, and in this case, but have low renin. Renin is low. This is primary hyperaldosteronism. This is primary in tumor, in hyperplasia, and in other case, because in other case, for example, in stenosis, renal artery. The patient have the same clinic, have hypertension, but in this case, this is a malignancy hypertension. malignant hypertension. The patient have high aldosterone and high renin. This is secondary hyperaldosteronism. This is the primary aldosteronism is a calm syndrome. It's a calm syndrome. In the secondary hyperaldosteronism, the patient have a metabolic alkalosis too, and this is the clinical presentation in different case, with different symptoms, but with the same diagnosis. The first compensation in this case is in the lung. When the patient decrease the respiratory rate and increase CO2, it's an acidosis respiratory compensation to metabolic alkalosis. That's okay. It's very important because this is the first mechanism of compensation. The second, this compensation is in the few minutes start to work, but the second mechanism of compensation is renal compensation, but is start between 24-45 hours. Is more 1 or 2 days start to compensation, but it's more accurate than the first mechanism of the compensation. I hope you enjoy with this case, and thank you so much. Goodbye.